Thank you, sir. Thank you for your wonderful. Maybe I'm supposed to talk for 20 minutes. Sir? Oh, this is a problem. So now, it is just like the last slide Dharmanand was showing inflammation and time resulting in damage. So this holds good for diseases of rheumatic diseases involving the lungs. Okay. Time lost is the lung loss. Okay. It is just like the lungs are the bystander, innocent bystander we can say. Because of its vast connective tissues that are there present in the lung and the vast network of blood vessels is bound to be involved in inflammatory rheumatic diseases. Okay. Again, coming, it is just like a Hamas war, Palestinian. Because IDF and then one side and then the Hamas on the other side. In between, the innocent civilians are caught there. It is just like that. Here we have got a disease, the rheumatic disease, inflammatory. Probably I am mostly concentrating on that. And then we have got drugs which used to treat the disease. Both are going to cause havoc on the lung. So diagnose whether the disease which you are dealing in the lung, involvement of the lung is because of the disease per se or because of the drugs which are using is an Herculean task. Again, after looking at the topic which was allotted to me, then and the hindsight now I was wondering, is it possible to cover this topic in 20 minutes? The early detection and evaluation of ILD and other pulmonary diseases in the rheumatic disease. Again, why I am saying this is, the rheumatic disease is is an umbrella term used to cover arthritis, several conditions that affects the joints, tendons, ligaments and many organs. So, which one should I talk about now in 20 minutes? Should I concentrate on particular disease of a rheumatic disease involving the lung like CTD-ILD, or should I concentrate on some host of other conditions? It's an Herculean task. There are more than 200 conditions involving the lung as far as this rheumatic disease is concerned. Okay. So lung involvement in immune-mediated rheumatic disease is very common. So I will be touching upon the immune-mediated inflammatory rheumatic diseases, what we call CTD-ILD. I will be concentrating on this topic because I will take 20 minutes if I want to do some justice to the topic. So the lungs any part of the lung can be involved in inflammatory rheumatic disease. It can be parenchymal like in the form of ILD, nodules, bullae, pleural like pleural pleuritis, effusion, pneumothorax, and the airways can be involved in the form of bronchiectasis, bronchiolitis, including the upper airway, and then pulmonary vasculitis, primary pulmonary artery involvement causing pulmonary hypertension or pulmonary vasculitis, or can cause capillaritis and pulmonary, intra-alveolar hemorrhage. Okay, just if I take a prototype of one condition, that is rheumatoid arthritis. So it can involve the upper airway, it can cause cricoid arthritis, cricothyroid arthritis, rheumatic nodule in the vocal cords. Okay, and it can airway, it can cause bronchiectasis, bronchiolitis. Okay, if you take the pleural disease, again you can see pleurisy, pleural effusion, pleural nodule, and then if you take the vascular disease, it can cause pulmonary hypertension, pulmonary vasculitis, and of course diffuse alveolar damage, and then it can cause Kaplan syndrome. Okay, it can cause secondary amyloidosis. And coming to the parenchymal involvement, which I will be concentrating on this, interstitial lung disease. So worst of, again under that, it's an alphabetical soup you can say. You will get confused, you lost in the sea. As I proceed, you will understand that. So it can cause usual interstitial pneumonia, non-specific interstitial pneumonia, organizing pneumonia, and lymphatic interstitial pneumonia, including rheumatic nodules. So which one should I talk about in this 20 minutes? It's again $1,000,000 question. Probably I will be concentrating on parenchymal disease, that is CTD-ILD. Okay. So if you look at this, what is the prevalence of CTD-ILD in India? Anybody? Do you have any data here, any registry? No, definitely not. Because of variable, no data as such is available, but I just rush through this, whatever the Western data that is available. So you have systemic sclerosis. In fact, it can be detectable up to 75% if you do autopsy, but clinically significant around 25 to 45%. Okay, and I will not go into the details about the clinical presentation. As far as the parenchymal ILD is concerned, what I do is, so most of these all inflammatory immune-mediated CTD ILDs, most of this parenchymal in the form of NSIP, that is non-specific interstitial pneumonia, is fibrotic, and if you come to the RA, it is usual interstitial pneumonia. It behaves like an idiopathic interstitial pneumonia. Okay, so if you look at that, most of the RA ILDs, CTD ILD, it is the NSIP which is the main thing that is involved in the lung, except RA. Of course, other things can be involved in combination, depending upon the underlying the type of ILD we are dealing with concerning with CTD. And if you look at the non-respiratory or the non-ILD manifestations, so for example, if you take systemic sclerosis, you can see pulmonary lymphomas, you can see because of esophageal dysmotility, you can see aspiration pneumonia. Again, they themselves is a different topic which you cannot go on covering them, all the diagnosis and early whatever. Early diagnosis, you can touch upon the diagnosis of those conditions also. Or you can again bronchiectasis, but then they are themselves a different topic. I will not touch upon those things. In fact, SLE, it can cause pleurisy. Common, the ILD, CTD ILD is very less common with the SLE compared with other types. Mainly, it's pleura which is involved and pleural effusion. So the diagnostic aspect again it differs depending upon the site of involvement. If it's a pleural effusion, simple diagnosis, you do the ultrasound guided pleural aspiration, send it for analysis, you will confirm the diagnosis. Okay. Then Joffrins, again the lymphoma, amyloidosis, bronchiectasis is a common presentation. Then of course NSIP as far as ILD is concerned, and MCTD again MCTD and SSC, they are notorious for acute presentation and acute respiratory failure. It is a nightmare for pulmonologists. When you see a patient, called to see a patient in ICU, already if the patient is diagnosed with CTD and already on treatment, if he is in hypoxic respiratory failure, it is a nightmare for us. Whether we are dealing with the disease worsening or whether dealing with the infection resulted from your immunosuppressor that is used. So that is the dilemma we get into when you see the patient in ICUs. Okay, look at the ILD resistive. This is the survey that has been done from 2012 to 2015 with a nodal center Jaipur. Okay, this one is with Dr. Raghu from University of Washington, Seattle. He is the main coordinator for this study. This is a prospective prevalence evaluation of this ILD. If you look at this, what you see here is CTD ILD almost is the second in the national registry. This is the only thing I think is available as far as the Indian registry is concerned. I don't think there is any prevalence that available for CTD ILDs or any rheumatic diseases involving the lungs. Among these CTDs, again, top three, first rheumatoid arthritis, scleroderma, MCTD appears to be the commonest. These studies involving the 32 centers, actually 37 centers spread across the India. So now what we will do this session, what I will do is I will define overview of CTD ILD and see the okay. Then it's heterogeneity, why there is a different types of alphabetical soup, and what is the importance of differentiating these different types of ILDs, and also from IPF and non-IPF, and what are the diagnostic challenges we face in diagnosing this ILD, CTD ILDs, particularly when it comes to early diagnosis and summary and conclusion. So as you know, ILDs are a heterogeneous group of disorders. They have got all similar clinical, radiological, pathological and pathophysiological features. That's why it is grouped under one term. There's a lot of more than 200 conditions fits into this. Because the interstitial is a misnomer because it can because not only the interstitial that is involved, there are distal airways and as well as blood vessels that are involved. That's why the actual term should have been diffuse parenchymal lung disease, which has been actually used. So I will not go into the anatomy of interstitium. Okay, why early diagnosis is very important? Because as I said, time loss is the lung loss. Whenever there is inflammation, there is a fibrosis. Ultimately, once there is a fibrosis, it is irreversible. So we know what happens when the lung parenchyma gets fibrosis. It comes in the way of oxygenation. Ultimately, patient will become in a respiratory cripple and it will be respiratory failure. Ultimately, leading lung transplantation. So pulmonary fibrosis again, it has got important for as far as prognosis is concerned, as far as management is concerned. Because nowadays we have got very good drugs which are antifibrotic. We can diagnose early, they are very effective in the early in the stage of development of fibrosis, and also for prognostification. The severity of the prognosis, bad will be the prognosis. So ultimately, the mortality and morbidity in CTD, not because of CTD per se, it is because of lung involvement. Particularly, if you look at the SS, with the main important subgroup that has been studied widely is scleroderma ILD. So scleroderma ILD with lung involvement, mortality is 2 to 3 times without lung involvement, and if there is associated pulmonary hypertension, it is further higher. So that's why early diagnosis is very, very important. If you look at the classification, you know the why there is a lot of difference. This is the one of the classification of interstitial lung disease, and usually they differentiate between IPF and non-IPF because they behave differently clinically as well as the treatment and its response is concerned. Okay, I will not go into the details. Again, the subgroup of CTD. Okay, this is the one which has got a best prognosis. We can pick them up early, treat them early, so we can prevent further progression of fibrosis and with good prognosis compared to other idiopathic variety and other ILDs. Okay, so I will not go into the details. That's the reason why we classify them as different varieties as far as we clinicians are concerned. So one group is IPF group, another group is non-IPF. Why? If you look at this, the survival curve, almost the IPF, almost you see this 5 years, survival is less than 50%. The other non-IPF group, it is better. Particularly if you see this second one, just I am showing this here is, what I am showing is IPF again, poor survival. Okay, so other group. Okay. So chronic, if you look at the chronic hypersensitivity pulmonary, it is a curable disease. Okay, if you avoid the precipitating factor early in the before the development of fibrosis, again you can have a complete cure and normal lung. But if it goes to chronicity, again it behaves like your other group of fibrosis, like idiopathic pulmonary fibrosis. That's why early diagnosis is very, very important in ILD. Any ILD for that matter, let alone rheumatic disease related ILDs or CTD ILDs. So any ILDs, any inflammation in the lung, it should be diagnosed early and treated early because of it has got its own prognostification, this one, and as well as treatment is concerned. So early diagnosis, again as I told you, there are a lot of things. There are a lot of groups that are there even under ILDs. So we will not go into the individuals as such. So I will go through. See, these are the things which are commonly involved. I will not go into the details again. So as I said, airway involvement is rheumatoid arthritis, the interstitial lung disease, again will have systemic sclerosis, and also of course there is NSIP, and because this polymyositis and dermatomyositis causing interstitial lung disease, particularly fibrosis, and of course respiratory muscle dysfunction which you see in polymyositis, that will act with the respiratory dysfunction and failure, and aspiration pneumonia and systemic sclerosis. They are specific to that particular group of CTD ILD that we see. But across the board, interstitial pneumonia is very common across all the group of this one, particularly SSC, and then your idiopathic inflammatory myositis like polymyositis and dermatomyositis. Non-specific interstitial pneumonia is quite common, and lung involvement in the form of interstitial pneumonia is quite common across the board, across all the group of ILDs. So that's why this will really a challenge, because to so many heterogeneous group of disease, heterogeneous group of presentation, and even the progression is different from individual diseases. So that's why it's very difficult to have a uniform protocol. So there is, because of various presentation and the drug-induced problems, infections, other comorbidities, complications, and we don't have no RCTs, how to go about diagnosing this to pick up early this one, no consensus, no international accepted protocols like other diseases. This has led to the problem in making the early diagnosis in ILDs. Again, we have one entity what is called progressive pulmonary fibrosis in ILDs. Okay, so the PFILDs, fibrosing ILDs, and again, how do you diagnose it? Any patient over 1 year, if there is a relative decline in forced vital capacity 10% of the predicted value, or relative decline in 5 to 10%, with either worsening of the respiratory symptoms or increase in the extent of fibrosis and HRCT, are worsening in the respiratory symptoms or increasing the extent of fibrosis on the HRC over the 1 year period. If there is a deterioration, clinical deterioration, and of course PFT, there is a decline in FVC of 10%, and the HRCT showing the worsening fibrosis, we say is PFILD. Okay. So again, coming to the diagnosis, as I said, so history, like any other thing, is very, very important. Then followed by examination, thorough examination, either to confirm other manifestations of the CTDs. Okay. Then chest X-ray again is less sensitive, and almost even in the hardly you can pick up by 20% of the cases, even symptomatic ILDs. PFDs, of course, again early ILD you may miss many cases. Again HRCT is the gold standard in diagnosing the CTD ILDs. Again FOB, again ball, the lung biopsy again is a controversial issue. Most of the time will not go for that. Ball is used to rule out associated infection and other conditions. Okay, it will not support the diagnosis. Again, lung biopsy, not many of these patients are undergoing lung biopsy. We do not advise that. Ultimately diagnosis. For early diagnosis, reverse this. As I said, HRCT is the gold standard. So most of the cases, sensitivity of more than 80%, we can pick up the early ILDs, followed by exercise testing, either 6 minutes walk test or preferably CPAT. So even when there is parenchymal damage that's significant, as it to be seen on radiological or on HRCT, you can pick up the physiological changes that's happening by exercise testing, and of course DLCO, transfer diffusion lung capacity for carbon dioxide. That's very, very important. Again, followed by spirometric abnormalities, then your chest X-ray and symptoms. Sometimes you have ILDs which can occur, which can antedate your other presentations. So what you call the evolving early CTDs. Okay, lung predominant ILDs. Sometimes only the lung involvement may be the initial presentation of your CTDs, connected to disorder sometimes in some cases. So this is the one of the studies is showing the sensitivity and specificity of each test which you use. Commonly use PFT, chest X-ray, and PFT and HRCT combination, and combination of all the three. PFT, that's the DLCO, and then chest X and HRCT. So ideally, the sensitivity and specificity will increase when we combine all the three tests. Almost sensitivity of more 95% and specificity of 77%. You know, the higher the sensitivity, specificity will go down. But combining all these three tests will have both specificity, increased specificity, and high sensitivity in picking up these ILD cases as early as possible. And another important thing is multidisciplinary discussion. We have to involve the pulmonologist, radiologist, rheumatologist, and pathologist. Pathologists usually CTD ILDs we have got hardly lesser role actually. Most of the things you can be diagnosed by CT, because CT is also an indirect evidence of histopathology. So certain cases when there is a confusion, then we have to go for lung biopsy. So this will not go into the details about that. Okay, this is very, very important when you are there is a confusion regarding whether the ILD is caused by either drug induced or other treatment is one and other things, and if it's not behaving like a usual as expected ILD. Okay, I will not go into the details about all these things, and of course X-ray. The later manifestation, you can see all these in the reticular nodular shadows, the GGOs, okay, all these things will not go into the details. Okay, HRCT, SHL is more sensitive in picking up early ILDs, almost 94% compared to chest X-ray, and of course it can helpful for exclusion of other conditions. If you see a dilated esophagus, it can give a clue to your systemic sclerosis, something like that. Okay. So I will not go into the details about the different this one you can see on the radiology, but one specific features of HRCT in CTD ILD, so particularly UIP pattern. If you see a rheumatoid arthritis patient looking at the UIP pattern on the chest X-ray, if they have a striated sign, we have got an exuberant anechoic sign and anterior upper lobe sign, it goes in favor of CTD ILD UIP pattern. So this is the striated sign. You can see the cutoff like a straight one, and the exuberant anechoic. Okay, though they are less symptomatic, unlike you see in IPF, the huge extensive anechoic you can see there, and anterior part of the lung that is involved. This is what you call upper lobe anterior sign. So these are for some of the pictures of NSIP and UIP, and most of the time you see in particularly say for example dermatomyositis or polymer. You see combination of NSIPR organized pneumonia, the picture you see like that. Okay, GGOs and consultations, I will not go into the details about that. And early again, we can suspect which patient is going to develop ILD by looking at some of the serological autoimmune parameters. Okay, like if the extended autoimmune panel like MDA5, you can predict that patient is going to develop rapidly progressive ILD. Or SCL70, you can predict that patient is scleroderma might develop. You can have at least you can guess which patient is going to develop ILD or progressive ILD by looking at certain of these autoimmune serological tests. So again, bronchoscopy, as I said, is not going to help us for diagnosis. It will help us to rule out any infection which you are dealing with, particularly when you see a patient deteriorating on treatment. And surgical lung biopsy, hardly we subject these patients for surgical lung biopsy, and most of the time it is only for the diagnostic confusion. After discussing with your multidisciplinary team, will go for surgical lung biopsy. Ball again, as I said, I told you, in some of the cases, we can, if the ball shows predominant lymphocytes, then we say, which is the case in most of the rheumatological diseases, and these are more steroid responsive. With more of a neutrophil, they are less response to steroids. That thing you can gain some this one. Otherwise, it's not indicated actually. Even the biopsy, as I said, it's not routinely indicated. Okay. The role of biopsy is if there are atypical symptoms and if the suspect again malignancy, infection, and vasculitis, then you go for and rapid worsening despite your clinical diagnosis and management, then you will go for biopsy. Then biopsy again, it's not transbronchial. Okay. For all different kind of ILD, it is only the surgical open line biopsy, Awards biopsy. And nowadays we can go for cryobiopsy. So you can get a big tissue because the small tissue you get through transbronchial biopsy is not sufficient to diagnose. As I said, HSCT is the gold standard in diagnosis. Okay. Again, lung function test, as I told you, again the risk of missing significant ILD. In the early ILD, lung function test may be normal, or it can overestimate the underlying ILD. So DLCO is affected also by pulmonary vascular involvement. Okay, the systemic sclerosis, then there is a pulmonary hypertension. Again, there is a very low DLCO compared to lung parenchymal involvement. Again, that's the problem. So HRCT extent, this is more informative actually. So HRCT is the gold standard for early diagnosis of ILD. Of course, PFT is very important for predicting treatment response. If there is FVC decline 5 to 9% and along with DLCO decline 15%, less than 15%, that means there is no evidence of progression of ILD. If it is more than 10% FVC decline or decline in DLCO more than 50%, there is evidence of disease progression. So that means you have to alter your whatever immunosuppressants you are giving, either you have to go for increase in this one. Again, risk factor for ILD progression, each again subgroup has risk factors. For example, one of systemic sclerosis, these are the risk factors which, if these are there, we can suspect that this patient is going to develop ILD. Or if he has developed ILD, it may be progressing rapidly. I will not go into the details about that. Again, of course, serological autoantibodies we do routinely, but biomarkers like KL6, these are all not routinely available, and it's not possible also to get those things done. At least we can depend upon the clinical, that male age, older sex, and then the shorter the duration. So the development of ILD and progression of ILD is in the first few years. First 1 year, there is occurrence of ILD and progression. After 3 to 4 years, chance of patient developing ILD and progression is very less. So shorter the duration, early disease, and then the disease extent, the severity extends more than 20% on the HRCT, and then the subtype of systemic sclerosis, like so all this will help us to predict which patient is going to develop ILD, so you can be prepared. The next few slides I show the different algorithms. This itself indicates that there is no consensus as to the approach to the diagnosis of ILD, let alone early diagnosis of ILD. So this is one of the algorithm where again history and everything is where that is as usual, and here the HRCT is the initial evaluation part, which we don't use. As I showed in my earlier slides, we start from history, then X-ray and other higher up. So HRCT is the first line to pick up early ILDs. Then of course your RT and the other autoimmune panels, then you will diagnose whether it's CTD ILD or again another term, okay, inflammatory pneumonia with autoimmune features, where it is not fitting into the known CTDs, because some antibodies are present, so there is ILD. So we are not sure whether it is dealing with CTD ILD or idiopathic ILD with some antibodies that are present, false positive antibodies. Okay. So what is important is continuous assessment of these cases for occurrence of ILD or presence of ILD. Again, SSC, there is another algorithm, PFT, DLCO, and again they will do lung ultrasound. Now lung ultrasound, if there is any fibrosis, thickening in the lung parenchyma or pneumonia, so you see the B lines. So quantification of B lines, we can pick up the involvement of the lung in the form of interstitial involvement. Now again, some centers they are doing that. Nowadays even the lung ultrasound has become the part of clinical examination, be it in ICU or in the ward. So now it is revolutionizing even the diagnosis of early diagnosis of ILD. So one of the algorithm, again I am not going to the where the source and other things. There are different algorithms used by different authors and different societies. But again, this is the simplest thing. Lung ultrasound is available easily and is less exposure to radiation. So PFT is available, the DLCO is available, HRCT available. Again, this algorithm is helpful for us to follow again. So again, this will pick up no ILD, then if no ILD, again you have to follow it up. I told you first few years is the period where there is occurrence of ILD and rapid progression. So first few years there is regular follow-up, there is no ILD. If there is ILD, depending upon the severity, again the follow-up again for 4 to 6 months or within 6 months, whatever. Again, you don't have to go for HRCT, again the radiation exposure. You can follow up with PFT, DLCO and lung ultrasound. Again,
sorry to interrupt, sir. Time is running out, sir. Sorry to interrupt, sir.
Yeah, finish up. So this is how the extent of this thing is done. This is another algorithm. So this is another algorithm. That means, so there is no consensus as to how you go about detecting these ILDs early. So this is the summarizing all the things. You can ILD screening in all patients, spirometry, DLCO, chest HRCT is available. Again, if FEC less than 80, DLCO less than 80%, yes, then follow up respiratory symptoms. That means there is an involvement of lung. Okay, the FEC is less than 80% and DLCO is less than 80%, less than normal. So stable disease, again, we don't have to treat, you have to follow it up again regularly. If there is a progression, again on repeat all the tests, then the chest HRCT, then treatment, again commendation whether to treat or not. If there is a progression, again frequent follow-up they need. Again you have to investigate with FEC, DLCO and HRCT. Okay. So this is again you can add 6 minutes walk test and ultrasound to the previous one. Okay, again the follow-up again depends upon the underlying disease process and severity of involvement and rapidity of progression. So this is again the summary of whatever the slides I have shown. So history taking, baseline evaluation, including symptomatology, 6 minutes walk test, sleep test if available and USD, then the FEC, DLCO, HSCT examination and regular follow-up depending on whether it's 6 monthly or yearly depending upon the progress of the disease and the treatment response. And HRCT of course once in a year you can go for if there is a rapid deterioration. I will not go into the details about that. In summary and conclusion, the CTD is highly heterogeneous group of entities related to, there's high mortality and morbidity related to lung involvement. This is basically because fibrosis, once the fibrosis occurs, is very difficult to treat, and the detailed history, examination and relevant investigations, keeping open the differentials. So multidisciplinary team discussion is a cornerstone to early diagnosis and correct treatment. And PFT, DLCO, 6 minutes swab test is easily available. Of course, X-ray, there is again the low sensitivity. For follow-up and other, you can pick up any pneumonia worsening, you can pick up with this. And it's important to recognize CT pattern. That itself will give some clue what's happening in you don't have to go for biopsy. Biopsy only in selected cases. And what is important is regular follow-up. So particularly if there is the isolated ILD without obvious CTD manifestation, and the time will tell us whether we are dealing with the CTD ILD or idiopathic ILD. The role of ultrasound, eNOS and these other novel techniques are being evaluated. Now ultrasound again, the asthma you use exhaled nitric oxide. Same thing may be used here also to find out whether the inflammation is happening in the lung. And ultrasound of course, many centers are using it to pick up early diagnosis of ILD. I think And of course, artificial intelligence may be famous a big way, because cough, characteristic cough can say whether there is inflammation in the development of airway or the ILD. People are doing that actually still in the trial stage. So the artificial intelligence also might help us in diagnosing early CTD ILDs. I thank you, sir. I took more time. There was a little confusion whether to which one to give importance, whether it's ILD or whether it's pleural effusion, whether it's organizing pneumonia. So then I thought I had to scratch my head to put it into one.
Thank you for the